The Bitcoin, Ethereum, and Blockchain Super Conference is coming to Dallas, Texas, February 16, 17, and 18 in 2018. If you know of a better way to get the latest insider knowledge about crypto, to hear directly from the top minds in this field, to interact personally with 800 fellow crypto lovers, hodlers, investors, miners, traders, developers, and founders, then I'd like to hear about it. If you don't, then you don't want to miss out. Register today for the Bitcoin, Ethereum, and Blockchain Super Conference. Go to bitcoinsuperconference.com and register today as a super early bird to get the lowest rates on tickets and hotel rooms. That's bitcoinsuperconference.com.
Welcome to Almost Here, Round the Corner Future Technology Podcasts with Richard Jacobs. Future technologies poised to transform our lives for better or worse are the focus of this podcast. Almost here means these technologies are now here and starting to be used, or just around the corner, from Bitcoin to artificial intelligence, 3D printing, blockchain, virtual reality, and more.
Hi, this is Richard Jacobs with the Future Tech Podcast. My guest today is Matthew Holt, co-chairman of the Health 2.0 conference. Matt, how you doing?
Very well, thank you. Glad to be on.
Yeah, thanks for coming. So can you tell listeners about the conference? What's the intention of it? What's it about?
So Health 2.0 has been going about 10 years. In fact, we're about to do our 11th annual conference, so I guess turning the clock to 11, coming up in early October. We have been sitting at the intersection of healthcare and new emerging technologies, primarily initially ones that were kind of what I call snack health, social sensors, mobile analytics, cloud, and then K for kindness because it's healthcare. So but the new technologies that anybody who's following your podcast would recognize because they're the ones that have been emerging and now dominate over the consumer and the enterprise space over the last decade or so in healthcare. And healthcare has been slow to adopt those technologies, so we've kind of been a little bit ahead of the curve there. So that's our main focus. And these tools get used in healthcare by patients, consumers, patient advocates, by clinicians, and more so by clinicians and some enterprises, and then by a lot of other people who are sort of circling around the healthcare system, such as payers, providers, systems, pharmaceutical companies, et cetera, et cetera. So we've been focused on that for 10 years now, looking at technology both in the U.S. but also across the globe. So that's really what we do. And our shtick as a conference is to show a lot of live technology. We do a lot of live demos, and we show a lot of new products and new emerging technologies that we think will be impacting the healthcare system in, sometimes 6 months, but more likely 3 to 5 years.
So what are some of the most useful and inspiring technologies you've seen, whether or not they're being adopted yet, but what excites you most? What's out there that's really cool?
Well, I think you can sort of take this historically because everything that we have looked at is still becoming a big deal in healthcare. And frankly, things take much longer than we'd like them to. So I think that probably, you could start with where we started, which is a lot of the online patient communities. People like Patients Like Me or Inspire or MedHelp, which started out as really sort of online chat rooms between patients, but started to add the ability for patients, particularly patients with rare diseases, in some cases, to track their conditions and share information between them about the impact of drugs and treatments and other things like that. So, I think that's a great start, and those communities have gone on, and many of them have added functions and features and apps for tracking and integrating that care and messaging it to providers. In some cases, providers and pharmaceutical companies and researchers have looked at those communities to try to understand more about what's going on with the conditions and actually use them in clinical research. So that's one great group. I think the second one, which is now becoming a bit more mainstream but took a long time to get there, is essentially what I call Skype for doctors, which was, we have an idea, we have a category called patient to provider communication. And if you think about it, for better part of the last 10,000 years, you went to see a doctor, medicine man, shaman, what have you. It happened with the patient visiting the doctor, sometimes the other way around. But in that case, it was a face-to-face interaction. The patient was told something by the doctor, and then the patient went away, and who really knows what happened next until next time the patient came back. And that's still the model, believe it or not, for 98% of healthcare delivered in the world. Of course, in the rest of sort of the enterprise and business world, we've moved on, and we have a lot of asynchronous and synchronous communication techniques, and there are many companies and which in the last decade or so have been building those for healthcare. And now you're starting to see the spread of video visits and now even asynchronous visits. And some of the new and more exciting versions of this are using artificial intelligence and bots to try to help so patients narrow down on their symptoms and get them to understanding and possibly to diagnosis and treatment even more quickly. I think that's an exciting area that's changed a lot. And I think that one of the things that's the impact of that's going to be is that over the next decade or so, the actual location of care delivery and the sort of how we organize care delivery systems, which are a huge business. I mean, in the U.S., we spend nearly 20% of the GDP on healthcare, and every town has a hospital, which is probably the biggest employer in that town. And many of our big cities like Boston and Houston, are dominated by these massive medical complexes. That's all going to start changing because we're going to start shaking out how we deliver care, and a lot more of it's going to be delivered virtually or even delivered automatically. So I think that's the second one. And I think the third one, which is probably the most exciting, but is really just coming, is using the power of the processor and the sensor, which are, in the smartphone, but also in many other things. The Internet of Things, of course, is a big play here, to do a lot more continuous monitoring. So if you think about it right now, you've all seen the TV shows, people are in the ICU after surgery and there's lots of machines plugged into them and they're going beep or ping or what have you. We're moving now to a world in which the sensors involved and things for tracking things like blood pressure and heart rate and, weight and a bunch of other, and temperature and a bunch of these vital signs, or for people with diabetes, things like blood sugar levels, or for people with asthma, peak flow or the regularity of needing an asthma medication, rescue inhaler, that kind of thing. A lot of those devices are now starting to appear connected to the Internet of Things in the bathroom or the living room or wherever, or the bedroom, wherever people do these things. And I think, again, this is early stages, but you're starting to see a lot of tracking of this. Half of it is kind of for healthy athlete types, weekend warriors, getting their Fitbits, and Fitbits now, those kinds of companies are now tracking sleep and heart rate and that kind of stuff. And the other half is for pretty sick people who've been discharged from the hospital and now come home instead of with either not going home, now have patches on them which track the heartbeat and respiration and that kind of stuff. And you're going to see much more of that. And I think the gap between those two groups is going to be filled. And most people with some level of chronic disease, which is a huge number of people, about somewhere between a quarter and a third of the U.S. population has some kind of chronic condition, we'll find that they're going to be tracked much more regularly rather than just kind of being tested once they go to the doctor every 3 months or how often it is. And I think it's very exciting to see the rise of these kinds of sensor-based monitoring systems. And that leads us to another area of technology, which is some people call it deep search, or some people call it artificial intelligence or natural language programming, or whatever you want to call it, which is trying to figure out from all this data what's actually going on with people. Because we're seeing a lot of data starting to come, and we haven't really figured out how to track it, and the whole sort of idea of how to advance clinical understanding and how to figure out that some of these diseases which we thought were one disease, maybe 15 or 20 diseases, and how do we personalize treatments for individuals and how to change their drug regimens and that kind of stuff. There's a whole bunch of work to be done on that, which will be advanced by this new type of sort of monitoring technology.
So why is the medical industry so slow to adopt something you'd think that's simple, like doing a consult with your doctor over Skype instead of having to go to their office? What's the holdback, the resistance?
Yeah, so the resistance is three main things, and any one of them most of them don't exist in other entities, in other industries, so it's actually not that surprising. But I call it institution, profession, and incentive. So we have large institutions in healthcare, predominantly hospitals, but also other ones, which, because of their history, have a sort of special place in the political ecosystem of not only this country but many others. So it's very hard to close down hospitals. So if I figure out Amazon and I can put Barnes & Noble out of business, or is it Borders, whoever they put out of business pretty quickly, there's no wailing and gnashing of teeth about that. That's business, and it's a cash-based payment, and off it goes. The Barnes & Noble or the Borders equivalent, the big hospitals, they get most of their money from the government. There's a very complex way they get paid, and they have lots of political influence in that. And they're also very large employers in their individual regions. So it's very hard to change them and to replace them. You've come out with a better idea. Just the weight of the institution means it's hard for the institution to change, and that means it's hard for it to change internally because they don't have the same kind of drivers that for-profit businesses do, where they go, if we don't get it right, Amazon will put us out of business. And by the way, It's hard for those for-profit businesses to change. Plenty of for-profit businesses go away, even though they just have the same incentive as profit maximization. They still get it wrong, right? For a lot of internal reasons. So that's what. The second is profession, and in particular the medical profession, but other parts of the healthcare, labor force have got a lot of history and not only history but also regulation and education around what they do. And essentially, the doctors, there was a big change in medical education called the Flex Report back in 1917, I believe it was. Might have the year off by a date or two, which changed how medical education has been done for the previous 80 years and made it a lot better. But it hasn't really changed since. So the way that we teach doctors and the way that doctors go through through undergrad to medical school, through residency, and learn sort of from the feet of the bedside of the masters, and the way that the money flowing into education and then into these large academic medical centers and medical schools renders the greatest prestige to specialists and sort of doesn't encourage sort of radical innovation, and instead encourages sort of following along in a profession, means that although there are lots of doctors who want to change what they do, it's hard for them to do that. And there's this big professional weight, and then you have things like the American Medical Association, the specialty societies, all of which there's a lot of ways. If you want to change something within healthcare, a lot of politics in doing that. And again, they also have a lot of say over how the money flows. And the third one is the money, it's incentives. It's not quite exact, but about in the U.S., about half the money comes from a government program, Medicare for the over 55s or Medicaid for the poor, and now the working uninsured, or the Republicans may be changing that this week, we'll see. And then the rest of it, the majority of the rest of it comes from probably the way you and I would get our insurance, from our employer. Employer pays for it. And it's all essentially routed into a system that was set up in the 1930s by the Blue Cross plans when they were established, which got locked into place by the introduction of Medicare and Medicaid in the 1960s, which is known as the fee-for-service system, which essentially means that every process or transaction or thing that the health system does to you, it bills and gets money for. So it's set up to do more and more things to you. And a lot of and this is basically still despite a lot of attempts to reform, this still basically how healthcare is paid for. And if you think about a lot of the use of information technology and these kinds of new technologies to do things a different way, they are a lot of the sort of long-term outcome from them would be that you would change the way that you deliver care. But the incentive system is set up with a very, very detailed system of payments for particular activities that may not include these. So, for example, we talked about virtual visits and telehealth. It's been a sort of 20-year battle to get Medicare to pay for these things so that you could, instead of doing an in-person visit, do a virtual visit. And it's really only the last 5 years or so that even insurance companies have been prepared to pay for that. So getting these things changed ends up being a big political battle, and it just takes a long time. So even if you could flip the switch on the institution part, the profession part, or the incentive part, you'd still have the other two to hold you back. I think those are some of the reasons. Now, you'll also hear other people say, well, healthcare is incredibly complex. It's a life or death issue. We can't just take on new technology because, you might start killing people. We already do plenty of killing people within the healthcare system. There's lots of medical mistakes and lots of medical errors and things that technology potentially could solve. But I mean, that's been part of the reason. And if you want to see a reason, an example of how we did actually take on more technology, the last 5 years or so, the U.S. has gone from being roughly about 25% of clinicians in hospitals using electronic medical records now to about 80%. And that was purely because the government so said you had to and paid for it as part of the Obamacare, part of the Recovery Act. And in 2009 had about $30 billion in it for electronic medical records. And so we spend that $30 billion putting in kind of 2005 style technology, which most hospitals and doctors now have. Kind of a pity because now it's 2017. We could do better, but we could. You can move the needle on technology if we're prepared to change the incentives.
So what have you seen, or what do you think will be the positive benefits of new technology being adopted by the medical profession? Electronic records, visits and follow-up, perhaps through Skype sensors so people can monitor themselves a lot more closely at home, and then interpretation of that data. What do you guess will be the benefits? The size of them, the scale of them?
Yeah, I think when it is a hard one to track, but there's no reason why we can't deliver better care for lower cost. The vast majority of the cost in healthcare get spent on a very small number of people. And the old adage is it's 80-20, 20% of people cost 80% of the amount. It's actually, 10% cost 50% of the amount, and there's 2 to 3% who cost 20% of the amount. So, you can imagine that people are very, very... So if you can figure out a way using better monitoring, earlier intervention, tools like AI and virtual visits and coaching to persuade people who have got chronic conditions to change their lifestyle. The old adage of getting the person who has diabetes to start going for a walk and eating less sugar and and checking their insulin, checking their blood sugar levels and using the proper number of insulins. You can probably reduce the number of people who end up in one of those what healthcare what's called high acuity settings, which is even having a lot of stuff done to them on an outpatient basis or having to go to hospital. So you can probably reduce a lot of that. And there have been people who have been relatively successful in a relatively small scale about doing more intensive coaching, more intensive follow-up, and often not with the benefits of great technology, and sort of saving, improving out health outcomes and saving, between 20 and 40% of the overall cost in relatively small populations. The idea of technology is that you can do the stuff at scale, right? So that you can give these things to everybody and that they start getting relatively cheap. And you can start changing how you put the healthcare workforce together to monitor. When I say put it together, how you compose the healthcare workforce and what they do. So they're doing sort of more monitoring of the chronically ill and more education and more sort of prevention than cure towards the end. So that I think would be the optimistic way of saying how you think, how this should play out and what the long-term benefits should be. And you can see this in lots of individual cases. I mean, there's a company called Iora Health, which is essentially a startup physician primary care clinic that literally allocates coaches to all of its chronically ill people. And these people using a combination of, the phone, some IT, some technology, and even in-person visits, they essentially bug the crap out of these chronically ill people, get them on their side, change their behavior, and they find that they can start really literally changing how they're changing their outcomes by helping them through the process. And that reduces the likelihood that they go to hospital, reduces the likelihood they go to the emergency room, reduces the likelihood they have complications down the road, which might include blindness or amputation or something like that for a diabetic, which can be very, very serious. So that kind of thing scaled by technology, I think, is probably our best shot. The issue is, of course, that we're going through, when you're trying to introduce this type of technology and no one's absolutely certain, what happens next, and and we don't have a really clear roadmap for how to get from here to there, you have a lot of dislocations. And I think a lot of the complaints from the medical profession and clinicians as a whole as to the introduction of technology has been that it's sort of stopped them doing their work rather than help them. So that's a question as to whether the next generation of technology helps rather than hinders. And we all have examples of technologies that have come into our lives that sound like they should be great, but for some reason don't work very well and probably get in the way of our workflow. But we also have examples of technologies that come into our lives and suddenly make things that were very complex much easier. So we've got to hope it's the latter in the healthcare case.
What conditions? I mean, you talked about diabetes a bunch of times. What are some of the conditions that you think would be most helped by all this technology being used by the medical system, and which ones do you think will have the most benefits society-wise?
So the biggest problem, is what health policy wants to call NCDs, which is non-communicable diseases, which really are lifestyle diseases, and they cost the most money. There are certain things that's hard for the healthcare system. It's hard to deal with, on its own. So there's a lot of money spent on trauma between traffic accidents and gunshot wounds and what have you. And that's not a healthcare system problem. It doesn't fixing it up. But the big categories of diseases where most of the spending is and a lot of the suffering are the big chronic disease categories. So diabetes is the biggest and most prevalent. There are things which are connected to usually diabetes is one, connected to obesity, but things like heart disease, lung disease, pulmonary disease, COPD, congestive heart failure, heart attacks, those kinds of things. A lot of this is that not only years before these things develop, should we all be eating better and walking more and all that kind of good stuff? And eating right, and not doing what I did last night, which is found there was some ice cream cookie dough in the fridge and had that in front of the TV. But additionally, there's actually things you can do right at the point of when these things are happening. So can you actually work with people who are very close to the edge by sort of bringing them back and having them lose a few pounds? There's a number of companies now and programs now running sort of interventions that look kind of like Weight Watchers. There's a company called Armada Health which does this, another one called Canary Health which does this, which are essentially interventions to help patients manage their weight when they're on the edge of just going into that, getting diabetes. Programs sort of it's called metabolic syndrome. There's also another bunch of technologies and companies who are trying to help people who have either just been discharged from the hospital, have got one of these long-term chronic conditions, manage their life better, whether it's diabetes, heart disease, or what have you. And a lot of the same things apply. A lot of it's around diet, exercise, monitoring blood pressure, and that kind of thing, and using technology and coaching to do that. So you're going to see a lot more of that. So if you could get at those big disease categories and the kind of things that you hear about, like high blood pressure and high cholesterol and the heart disease and even monitoring people who've been released from the hospital who've had a condition but making sure they don't go back, which we're starting to see. If you can get at that, you can get at a bunch of the big disease categories. The other major disease category, which is harder to figure out, but also is having some changes, is all the cancers. And there is some link between obesity and lifestyle and cancer, and obviously some lifestyle conditions like smoking obviously relates to lung cancer, and there are some other environmental factors that relate to cancer. But because cancer is a fast onset disease in general for much of it, and requires a lot of intensive activity and care for people up and down the age range, rather than something that you get, didn't have 35 years of bad life that gets you to breast cancer, it appears pretty quickly. You're starting to see some people trying to figure out if there are ways that you can use data and technology to not only manage the process of cancer better, deliver more accurate care based on genomic and other omic factors, and also try to figure out from the data we're collecting, what works and what doesn't. Because in cancer, there's so much different activity and so many different new drugs being tried all the time. It's actually, there's a data collection problem in that. Whereas kind of for diabetes, we kind of know what to do, but don't really do it well. In cancer, we generally don't really know what to do. That's a gross oversimplification, and many oncologists will be beating me up for hearing that. But we have a lot more to learn, I think, more quickly in cancer, and technology can help that. There's some interesting companies which we feature Health 2.0 doing some of that. One of them has got a lot of investment from Google Ventures. It's called Flatiron, and they're trying to basically capture as much information about cancer. They're providing that electronic medical record out to oncologists. They're capturing information. They're doing a lot of deep learning on that information, on the data they're bringing back, and they're trying to figure out, essentially what works and what doesn't in terms of different drugs and different trials and that kind of thing.
So on the cancer front, which I guess all these new initiatives and this new technology you think will help, any other new technologies you think are going to be really important to the medical profession for cancers or for other conditions, diabetes, et cetera? Anything you haven't mentioned yet that maybe it's too soon? Maybe it's a technology that.
So I think there are some technologies that are going to dramatically impact the medical profession that I haven't really mentioned yet. So I think one of them is the sort of increased number of things that we are tracking. So we mentioned the genome briefly. So I talked about essentially vital signs, hypertension and high blood pressure and weight and what have you, and those are very, very important. Then you've got this enormous amount of data coming down the track around the genome, and then you have people who honestly believe that may be right, but a lot of this stuff is connected to what's in your microbiome and your gut, proteomics, and there's all those omics. And so we're going to be testing a lot of different stuff and seeing what looks out. And I think that for the medical profession, helping trying to keep up with us using essentially AI plus, clinical decision support to help keep up with all this information that's going to be a big piece for people who are doctors to figure out. The other thing is going to be using robots of various kinds to do lots of different things. And you're already seeing robotic surgery becoming quite a big deal. But I think a series of, you can see across healthcare, a series of use cases for robotic assistant in many different areas. So one I would pick that is relatively obvious and people are working on is in the mental health area, where a lot of people are starting to use avatars, in some cases virtual reality and what have you for robotics. I use that word very widely here. Maybe a virtual robot to do patient monitoring and patient treatment. But even in some other areas, for example, I do a decent amount of work in Japan, and in Japan there's a massive imbalance in the population. They have a lot more elderly people and not enough young people to look after them. And I think you're going to see a lot of robotics to do very basic, care, literally care and feeding of seniors in nursing homes. And a lot more of that stuff is going to be outsourced to robotics. There will be the kind of nursing equivalent of the driverless car. You think about where that's heading.
Right.
So I don't know where you are in the sort of driverless cars here by next year versus 2050, but they're coming at some point, right? And I think you're going to see
I think pretty soon.
That level of robotics somewhere in that time frame come into and start assisting, widely across the healthcare system. So quite when that starts to impact what doctors do, and when you get assistant surgeons and nurses and what have you who are robots or assisting, I don't know. Clearly, you're going to start getting that on the AI front in terms of the clinical decision support and other decision support from the medical Siri or the medical Alexa in 10, 15 years time, which is and even the IBM Watch is trying to do this right now. So I think you're going to see a lot of that stuff impacting on how the medical profession works over the next 5 to 50 years.
All right. So, we're coming to the end. Tell me a little bit about the conference. When is it? Where is it? And what are some of the highlights of what's going on with the conference this year?
Yeah, the Big Health 2.0 conference is in Santa Clara, California, October the 1st to the 4th. We have a bunch of different pieces go on. We'll be touching on a lot of these things that we mentioned, diabetes, cancer, looking at how new technologies and new care organizations are sort of coming around to work, to work with patients on that. We'll be having a whole series of sessions on data analytics, artificial intelligence, and the impact of those types of technologies and how healthcare organizations are adapting and how they're using them. We will also look at some things that are not technology-based. We have a whole session called we used to have a session called the unmentionables, which are the things we didn't talk enough in healthcare, and we've now moved that to the unacceptables, which are some of the things that we don't think about in healthcare, like the lack of diversity in technology and senior levels in healthcare, epidemics of loneliness for patients and seniors, physician burnout, some things that are going on in the healthcare system we want to shine a light on. And then we have a lot of work on some of the underlying technology issues. We'll be featuring blockchain. We feature a lot about the emerging APIs in healthcare and how that's helping to move some of this data around out of the data silos that a lot of healthcare's data has been stuck in. And we'll be looking, and we'll be featuring a lot of new technology companies across the board in these and many other areas, electronic records, new ways of doing patient care management, new ways of doing hospital operations. We feature about 150 to 200 live demos of technology, so far too many to capture in this, but a lot of those things will be featured at the conference. And then we have panels for investors, panels and sessions for hospitals and providers. We have a breakout session purely for patients. We have a breakout session for for techno geeks, literally looking at sort of technical issues around APIs and that kind of stuff. So it's a big conference, about a couple of thousand people, big city hall of more than 100 companies, and sort of if you care about new health technologies, it's a great place to be.
And where's the website people can go to get all the information and to register?
Please, you can find us at Health2Con, which is health, the number 2 con, C-O-N, health2con.com. At Health2Con on Twitter. You can find me at Boltyboy, BOLTYBOY. You can find my co-founder and partner Indu Sabaya at Blue Topaz, or you can Google Matthew Holt, and I come up pretty quickly. There's a fashion model in London who is younger and better looking than me, but otherwise I'm kind of usually the next.
Well, hopefully with you being surrounded by all this health stuff, you'll find like an elixir of youth and overtake that person. So.
Yeah, I'm not sure that technology is quite, although there was a guy called Aubrey de Grey wandering around Silicon Valley promising that he's going to fix that, but I'm not quite sure that one's coming in like 5 to 10 years. And even if I was younger, I'm not sure if he's good looking as that guy. So.
Well, Matthew, thank you so much for doing the call. I really appreciate it. And, no one likes going to the doctor. No one likes the way the healthcare system is right now. So I know we're all hoping for these improvements you talked about to become widespread. The sooner the better,
Absolutely, and we're Richard. We're We're optimistic, but realistic, I think, about the way it comes. But unless you show people the possibilities, and that's kind of what we do in our conference world, then everyone's going to sort of be accepting of the normalcy they have now. So we're hoping that people will, both consumers, employers, payers, governments, and people in the system will realize that they can do a lot better because we should be able to.
Yeah. Well, very good. Well, thanks again for coming on the podcast. I appreciate it.
I appreciate your time.
The Bitcoin, Ethereum, and Blockchain Super Conference is coming to Dallas, Texas, February 16, 17, and 18 in 2018. If you know of a better way to get the latest insider knowledge about crypto, to hear directly from the top minds in this field, to interact personally with 800 fellow crypto lovers, hodlers, investors, miners, traders, developers, and founders, then I'd like to hear about it. If you don't, then you don't want to miss out. Register today for the Bitcoin, Ethereum, and Blockchain Super Conference. Go to bitcoinsuperconference.com and register today as a super early bird to get the lowest rates on tickets and hotel rooms. That's bitcoinsuperconference.com.
You have been listening to Almost Here, Around the Corner Future Technology podcast with Richard Jacobs. Subscribe to this podcast, post a review to discover more future technologies that are poised to transform our lives for better or worse, such as Bitcoin, artificial intelligence, 3D printing, blockchain, virtual reality, and more.